So thank you everyone for joining us today. We're going to spend some time talking about how nursing students make an impact through service learning in our rural Indiana areas. And just some quick introductions before we get into everything. My name's Britney Arce, and I'm a clinical assistant professor with the IU School of Nursing. And I've had the privilege of having Aiden and Ricky in a few different courses, so I'll let them introduce themselves and then we'll get started.
Hi, my name's Aiden. I'm a senior at the School of Nursing here, and I've had Dr. Arce as my professor in a couple previous courses. We've attended some of these screening projects, the healthcare screening projects, as part of our clinical, and as well as a part of our honors research project. And I've even gone to a couple of these as a part of the Red Cross to present some hands-only CPR training.
My name is Ricky Wase. I'm also a senior nursing student at IU Bloomington. And similar to Aiden, I've had Dr. RC in a couple of my classes, clinicals, and also a lot of extracurricular activities like honors, like Aiden mentioned. And I've been to a lot of these clinics as well doing the surveys.
Thank you both. So I'll go ahead and get started with this. One of the biggest things was I was really thankful that Aiden and Ricky could join me today because I know it's great to hear from the academia side with the professors on what we do, but it's even better when the students can actually tell you from their experience what we do. So with this presentation today, I wanted to go over from the classroom to the real world and how we bring service learning to life and students can really apply what they're learning. So with these health screening clinics, we're able to have students not only apply service learning, but also critical thinking skills. They get great hands-on experience with people, collaborating with other community partners, as well as some other schools at IU that I'll go over in just a moment. Real world experience for sure. I never know what people are going to say when they walk in the door. I try to prepare my students for as much as I can. Sometimes people come in and they want to tell them all about their life experience. Sometimes they come in and they're really nervous. Maybe they don't have a primary care provider and they're kind of scared of what their results might be. So it's really great for them to have, again, those critical thinking skills and work on their communication skills as well as, the hands-on skills that they've already learned. So the community engaged learning is a piece that I'm really passionate about that not only looking at what community needs are, but I can only teach them so much from a textbook, and I want to get out there and have boots on the ground and actually do this work with them. And one of the greatest things too is it's free to the community with the grants that we've been able to get through this. So the two areas that we serve in Indiana are Orange and Lawrence counties, and I have those circled here on the map for you. Oops, my thing moved. Move it down to Lawrence and Orange. But the Lawrence County census is 45,011, and Orange County is around 19,000. So we're in Monroe County. That circle needed to be a little bit bigger, but we actually go down to Lawrence and Orange for all these. The ones that we're in the most are Mitchell and French Lick areas. So we have done some of these health screening clinics in Bedford and Paoli, but most of the time we're in Mitchell and French Lick. And as you can see, the populations there are very low in those areas, and there's not always a lot of resources. So we wanted to go to people to be able to bring some of these resources to them as well. With the critical service learning, that's something that as not only as a nurse, but also as a nursing professor that I'm really passionate about, that I want to engage my students in the knowledge from the classroom setting and really being able to apply it in the real world setting in the community. So it really emphasizes building those authentic relationships with community partners and enabling the students to apply these nursing concepts around a variety of settings. So for instance, even though we're doing these health screening clinics and it's all about preventive care, which I really want them to know more about and we need to be more involved with, it also helps them when they work in a hospital and they're trying to do discharge teaching. So they can apply a lot of these, they can see what people are needing. It makes them take more time on what those needs are and how follow-up care works and how crucial it is to take our time with those discharge teaching. And even if they want to work in a clinic one day, or a hospital setting, they can apply a lot of these same communication skills and the critical thinking skills as well. And the equipment that we use now are actually used in physician offices, so they have that experience as well. And they really learn best with these real life experiences. Again, I can tell them case studies and put them in mock situations, but when they're with a real person, it just really helps them apply all their skills at once. So I wanted to go back and tell you how we started these health screening clinics. So the first one that we did was actually in fall of 2020, so before Ricky and Aiden even joined the School of Nursing. But it started then through the pandemic. So at that point in time, we were just getting back into clinicals after there was a huge pause in nursing and medical schools and others with that critical hands-on experience that our students need. We were getting back into it, and not all facilities were even letting us back in the doors. But then also I saw the need in the community that a lot of people, including the patients that came to these, weren't even having their normal primary care appointments because primary care physicians are being pulled to the hospital for those needs. So then chronic conditions were getting worse. So we started off with just a over-the-counter glucometer, some blood pressure cuffs, had the Hope Resource Center, which I'll tell you more about in a minute, come, and we just did blood pressure screenings, vital signs, and some glucose testing for people. And we were already starting to make a difference. So from there, we expanded. Like I said, the Hope Resource Mobile Unit came, and it's all about preventive care. So they actually have their own clinic in Bedford, Indiana, but their mobile unit, they're able to do free ultrasounds, free STI testing. All that's through grant money and donor funding, and they can also do free pregnancy tests. So they were also showing the community what their services were. Then we expanded in spring of 21 through IU School of Nursing. The Center for Rural Engagement at Indiana University wanted to partner with us because they had some grant money to purchase equipment to do cholesterol panels, as well as glucose. So we started doing those in some spaces in Orange and Martin County. And with those, they were appointment based. So people had to make an appointment to come to us. We later realized that the best approach would just be walk-in. So that way we were open to anybody, we were ready for anything. So we changed our resources and everything as well. And in fall of 21, I was able to thankfully purchase some better equipment that we use still to this day through some grants through the Center for Rural Engagement and with a partnership with Southern Indiana Community Healthcare Group. So that partnership with Southern Indiana Community Healthcare Group allows us to function these clinics. I have an algorithm that we follow under the physician's guidance because it's completely nurse ran, but I have that I follow. And then we also have some follow-up care if somebody doesn't have a primary care physician, the SICHC group agrees to take them on. So with all that funding, we were able to start doing hemoglobin A1C testing, which is great because people don't have to fast for it. Then fast forward to spring of 22, we expanded services even more with IU Health community nurses that come and do health coaching, which I know Ricky will tell you more about, and also IU Health Positive Link. From there, we even expanded our services to include nutrition services with the School of Public Health, and the IU School of Social Work joined us as well. And after all that work, I finally decided that, you know what, I should probably gather some of this data. So I finally got an IRB in place, and we actually get a copy of those results, and we're able to share those results with you today of what we've collected so far, which helps us to even more show that there's a need in the community and we want to continue these services. So I wanted to expand a little bit on who our community partners are, and some of you that are online may know some of these partnerships as well. So the Hope Resource Mobile Unit is located, or Hope Resource Center is located in Bedford, Indiana, and they have a mobile unit. So again, they bring those services to the clinics. The SICHC group I told you about, their main office is in Paoli, and we've had a partnership with them for a long time. Partnerships also expanded through IU Health Community Nurses that help us with health coaching at these events, the IU School of Public Health, their nutrition department, and then also Here's Your Health Check, which is a service that they also offer with the School of Public Health that they go to various community events. And they even do things like range of motion, grip strength, and other resources. IU School of Social Work also comes with some of their undergrad and graduate students and offer their services. And then the IU Health Mobile Unit, Mobile Lung Unit recently joined us this past year. So it's a win-win on prevention care that they're actually able to come to events that are already happening. And then we're able to expand our services to the community more so than we were already doing. The other thing that's nice about this, especially for the students, is that these are embedded into their curriculum. So with Ricky and Aiden as an example, they have a certain amount of clinical hours they have to have in nursing school in order to graduate. And these health screening clinics, between the training and everything, and even being there in person, they count these towards their clinical hours. So I was able to make sure that these fit our course competencies, which they do. We prevent, some of the course competencies I've listed here as far as prevention strategies, making sure things are cost effective, that we're in the community incorporating the use of technology. We do that a lot, not only with the patients, but their families and the community. And then also they meet other course competencies such as using evidence-based practice for our patients. We always make sure we're keeping up on the latest guidelines and involving the teaching and counseling with these screenings as well. And then just assessing the needs of the community. We're doing these screenings, but are they still needed? And Aiden will be able to share that with you later in the presentation with the results section. So it's really a win-win for the students and the community members, both with these health screening clinics. So now I'll hand it over to Ricky and he'll tell you more details about what we do.
Thanks, Dr. Arce. I want to take you all behind the scenes a bit and show you exactly what we do, how it impacts the patients, and shaping our futures as healthcare professionals. So, when the patients walk into the community locations, we offer a highly comprehensive set of point of care testing. But before we ever even touch the patients, we go through proper training. And as students, we watch some instructional videos, practice the competencies, and then we are officially checked off by the professors using specific diagnostic machines. And we are trained to use the Apneon 2 for the A1C testing, the Cholestech for the lipid panel, and then the HemoQ to measure the hemoglobin and blood sugar. And if you look at the health screening flyers, you can see that we offer so much more, including the vital signs, oxygen saturation, blood pressure, and then we also collaborate heavily with other groups. And depending on the day, like Aiden mentioned earlier, we might have the Red Cross to teach hands-only CPR. And then the School of Public Health, they bring the veggie meter to talk about dietary habits. Community and other community partners handing out free naloxone kits, or other social workers discussing coping mechanisms. And the most vital part of our day is the health coaching. And we do this alongside a registered nurse, and we review the patient's health history, looking at an intake paper as they fill out their personal information, their current medication list, and any presenting problems if they have any. And the values from the tests we just ran, we will also look at those too. And we sit down with the paper to provide real individualized education. And this is where our textbook learning turns into real world nursing. To give you an idea of what health coaching looks like in practice, I want to share a couple anonymous patient stories that really highlights the reality of rural nursing. So an example I had was that I remember this really made me think of my critical thinking skills, because early in my nursing student career, I didn't have a lot of experience talking to actual patients, but I remember I took somebody had taken a blood pressure from one of our patients, and it was pretty high, higher than what she had normally expected. And then during the health coaching, we were able to talk to her, look at her paper, and examine and ask the proper questions of whether she had already taken her blood pressure medication in the morning already. And if it wasn't for the health coaching, we wouldn't have known to ask a question like that. And we were able to come to a conclusion that that was the real reasoning why it was elevated, yet because she hadn't taken her blood pressure meds in the morning yet.
So I also wanted to share a couple of patient stories that I've had at these clinics, because I think they show what the work kind of looks like on the ground. And the first is kind of the most common type of encounter that we have. Someone will come through the screening, will run their A1C, and the result will come back elevated, say like a 6.1 or a 6.3. And when you look at the patient, you can see it on their face. They don't really know what that number means. They're looking at you like, okay, is that good or bad? And then that's where we can apply some of the nursing that we've learned in lecture into the real world. Um, we slow down, we sit with them, and we walk them through it. I'll explain to them what a hemoglobin A1C actually measures, that it's basically an average of your blood sugar over the past 2 to 3 months. I'll explain that a normal A1C is below 5.7. That 5.7 to 6.4 puts them in the pre-diabetes range, and that a 6.5 or higher is an indication of diabetes. And then a lot of times these people will feel totally fine. They had no idea that they were at risk. So the conversation then shifts to what they can actually do about it. That includes diet, activity, and following up with the primary care provider. That moment where you can provide education like that, where you take someone from not really knowing or understanding their own health to getting a better idea of it is super impactful, and it happens at most clinics. And then I have another shorter second story, and it kind of taught me a lot about staying calm under pressure. Granted, this wasn't a life or death emergent situation, but it was still good practice, and it was really early on. So we had a participant come through and we took their blood pressure and it was pretty high. And in that moment, you can't really panic. You can't like show that you're super concerned in your face. The patient's watching you. So if they see that you're alarmed, they're going to be alarmed. And that's only going to make things worse. So I had to stay composed and keep my voice steady, explain what we're seeing, and talk them through the next steps that they needed to seek care. And this was something that did need attention somewhat soon. That experience kind of put into practice what we learned in the classroom about therapeutic communication and staying grounded in higher stakes moments. And you can study that all you want, but until you're actually sitting across from a real life patient whose blood pressure is in a high dangerous range, you don't really understand what it means.
So some patient interactions like this can lead directly to student benefits, and you don't just learn from the clinical skills, but it can also help find your passion. So something that I wanted to talk about was a benefit for me personally. And when I came into nursing school, my goal at the beginning was becoming a certified registered nurse anesthetist, and it was the highest level of nursing. And it also came with great money as well. So anesthesia just made sense. But after shadowing multiple CRNAs, and then also doing the clinicals and other extracurricular volunteer activities with Dr. Arce in the community. Uh, these events really completely shifted my trajectory, and seeing these rural health disparities really firsthand made me want to change where my true passion really lies. And because of this project and my past clinical experiences, I decided I want to apply to the family nurse practitioner program in Indy, which I'll start later this year. And my ultimate goal now is to open my own holistic clinic in a rural area like where we do our clinics. And I want to offer services that communities simply don't have a lot of access to. And these things might be like primary care, medically managed weight loss, hormone replacement therapy like TRT, and menopause support. And these clinic experiences really showed me that you bring the care directly to the community and you can change a lot of lives.
So those other stories kind of lead right into the student benefit side of things because all of those encounters teach you something that you won't get from the textbook. So for me personally, this experience I think has made me a more well-rounded nursing student. I came into this thinking I would just get some clinical practice, and obviously I did. I'm more confident with point of care testing, running the Afinion, the ClasTech, doing vitals and health histories. And I can do all that now pretty efficiently and accurately because I've had so many reps of doing it in a real clinical setting. But I think the bigger thing is what it kind of taught me about the community. Working in Lawrence and Orange counties, going back repeatedly, even seeing some familiar faces year after year, it kind of changed how I think about the populations that we're serving. I'm more aware of the general health needs in rural communities, and I'm more understanding of the barriers that people face, whether it's access to a provider, distance to a grocery store, or just not having the information that they need to make changes. And that kind of awareness, again, doesn't really come from a lecture. It comes more from hands-on real practice. And honestly, these screenings just made me more engaged. I care more about the community health because I've been a part of it. I've seen firsthand what it looks like when someone learns something about their health that they didn't know before. And I've seen what it can mean for a community to have access to free screenings that they wouldn't otherwise have. And that all is kind of shaping the kind of nurse that I want to be in the future.
So when we look at the core purpose of these clinics, it's to help the people know the risk of cardiometabolic diseases by providing access to tests, giving them these results, and assisting them with access to providers for care. In rural communities where transportation and proximity are massive barriers, like Aiden mentioned, setting up our clinics and inside these familiar borrowed community spaces is a game changer. And looking at the bigger picture, The benefit is heavily rooted in prevention. By being out there, more people will be aware if they are at risk for diabetes, obesity, or high cholesterol, and this in turn will help prevent these disease processes from worsening if proper care is obtained. And a lot of the patients we see are in that pre-diabetes state, and catching them early allows for lifestyle interventions that save limbs, preserve kidney functions, and ultimately can save lives. Finally, we are constantly evaluating the access need for rural communities, and an evaluation will measure necessary outcomes to make future improvements. We look at what is working and what resources the community is still lacking, and to continuously elevate the standard of care we provide. To formally track this impact, we received the IRB approval in February 2023, like Dr. Arce mentioned. And since the beginning of the screening clinics in the fall of 2020, we've served over 300 people. And what's truly amazing is that 98 of those people consented to provide a copy of their results to analyze. And we've established a good rapport in communities of Lawrence and Orange counties. And because of that trust, we see people return each year to repeat screenings and compare their results. And with that overview of the patient population, I'm going to pass it over to Aiden to dive into the specific clinical data we've gathered from those 98 people.
All right, so now we can kind of get into our preliminary data. And since March of 2023, we've held 12 screening events across both Lawrence and Orange counties. One thing to keep in mind is that approximately 25 to 30% of the people who attend our clinics consent to let us keep a copy of their results for analysis. So out of everyone we've served, we've had 98 individuals give their consent, and that's a self-selected sample, so it's worth noting, but it still gives us a meaningful snapshot of the health trends in this population. When we look at the demographics, about 81% of our consented participants were female, and the average age was about 58 and a half years, with a range from 20 all the way up to 91. So we're largely seeing middle age to older women, which is consistent with who tends to show up to community health events, but we do get a broad age range, which is considering or encouraging. So now we'll kind of move on to some of the labs and vitals data table, the results that we got. It breaks down our screening results, and I can walk you through the highlights. So starting off with cholesterol, our mean total cholesterol was 186, which actually is within the healthy range of under 200. So that's encouraging on the surface. But when you look at HDL, our good cholesterol, our average was about 54, which is below the ideal threshold of 60. And our LDL, the bad cholesterol, averaged 108, which is above the recommended cutoff of 100. So even though the total cholesterol looks okay, once you break it down, it kind of tells you a different story. And our triglycerides averaged about 124, which is within the normal range. For blood pressure, the average systolic was about 129 and the average diastolic was about 80. Now, a healthy systolic is between 90 and 120, and a healthy diastolic is 60 to 80. So our averages are sitting either right at or just above those upper limits. And keep in mind, these are averages. Our range goes up to 172 over 112, which is well into a hypertensive crisis. That is the that's kind of similar to what I was talking about earlier with the patient I had with the elevated blood pressure. So this data tells us that even though some of the averages look close to normal, there are individuals in this population who are at serious risk, and they may not know it if we didn't have these screening clinics. Okay, so now we'll get into the prediabetes statistics, which is probably our most striking finding. When we look at A1C data from our screening clinics, 29.21% of our participants fell into the prediabetes range, meaning an A1C between 5.7 and 6.4. To put that in context, the statewide range in Indiana from the Behavioral Risk Factor Surveillance Survey in 2018 was 9.34%. So our population is showing prediabetes at roughly 3 times the state average. And nationally, the CDC estimates that about 115.2 million adults 18 and older have prediabetes. Now, our sample is small and self-selected, so we have to be careful about drawing broad conclusions. But what this does tell us is that in the communities that we're serving in Lawrence and Orange counties, they have a real and significant need. These are people who, without our screening, may not even know that they're pre-diabetic, and the prediabetes is exactly the stage where intervention matters most. You can make lifestyle changes, dietary modifications, and follow-up care can prevent the progression into type 2 diabetes. Next is kind of the significance. So, what does all of this mean in practice? Preventative care is critical for helping people be the healthiest versions of themselves. And a big part of that is just knowing the details of your results, not just your cholesterol is fine, but understanding what each number means and what you can do about it. When someone's values are elevated, we have real actionable lifestyle changes that can improve blood glucose, blood pressure, and cholesterol. And when someone's results are normal, it's just as valuable to know what's going well so they can keep doing it. One challenge, though, is follow-up. The Indiana Diabetes Prevention Program offers coaching either virtually or in person, but the locations are limited, especially for rural communities, which will bring me to the next slide. So this is a map of where Indiana Diabetes Prevention Program coaching is available. And you can kind of see the problem. We've circled where Orange and Lawrence County is, and there aren't many options there. If you're in Lawrence or Orange County, your nearest in-person coaching site might be a significant drive away, and you may not have the transportation to get there. So virtual options help, but not everyone in these communities has reliable internet access or is comfortable with that format. And this is exactly why what we're doing matters. We bring screenings directly into these communities, identifying people who are at risk, and we try to connect them with resources. But the gap between identifying someone as pre-diabetic and getting them into a prevention program is a gap that we're still working on closing. So looking ahead, we have a few key goals. First, we want to continue our community screenings for A1C and expand our ability to identify other health needs as they come up. The screenings are the foundation of everything that we do. Second, we'd like to keep pursuing grants to ensure all of our services remain free to the community. Cost should never be a barrier for someone to know their own health status. Um, Third, we want to grow our partnerships, specifically for follow-up care. Identifying someone as pre-diabetic is important, but connecting them to a provider or a prevention program is where real impact will happen, and we need more partnerships to help close that loop. And finally, we want to keep building on the benefits that this program provides, both for the students who gain hands-on clinical experience and community health awareness, and for community members who get access to care that they might not otherwise have. It's a model that works pretty well for everyone involved, and we want to keep seeing it grow. And then here are references. Thank you everyone for your time, and now we can open it up for any more questions as well.
Yeah, please feel free to submit questions to the Q&A, or we can open it up so you can ask your question live. And while we're waiting to see if we have any questions, we do have another 2-question survey we would like for you to take. Maybe just a minute.
So Carolyn, while we're waiting on questions, I might ask you a question that we didn't cover or elaborate a little bit more on. So one of the things with these health screening clinics too, since we are collecting data, that was something that Ricky and Aiden were able to be a part of as well. So I don't know if either one of them or both want to share what you had to do with that and even the learning processes of that, of like the importance of collecting data, but also not wanting to just bother a person with tons of questions, and how to approach that as well.
I can talk briefly about that. I remember, so specifically in our honors program, me and another classmate, we are also working on a different IRB. So sometimes we would double up with surveys, and I would ask a survey questionnaire during their time at the A1C station, and then other times they would go to the health screening, and we would ask a longer survey after their health screening. And a lot of times, some people were kind of dragged to be at the health screening clinics by their family members that just care about them, which is great. And it would be sometimes difficult to try to make sure to grab their attention and ask if they would like to participate in the survey and answer the questions.
To add on to that too, sometimes with a lot of these participants, you saw the oldest age was 91. So we have some older participants coming to these clinics who are not super familiar with technology. So the survey that they take afterwards is on a computer and it takes maybe 10 minutes to complete, but a lot of times they have trouble navigating it or figuring out where to go. So that's where a couple of times me, Ricky, and some of our other peers would sit down with them and kind of walk them through the survey, make them feel comfortable answering all the questions, explain anything that they need help with, and eventually get the information. We also have to make sure we disclose that, like, we're collecting this data from them and what it's for. And most of the time, they feel comfortable with that if they decide to stick around long enough to fill out the survey.
Thank you both for answering that. Carolyn, is there anything else you would want us to maybe go over more in depth with, if other people don't have questions?
That's if you want to go over other things, that's fine.
So one of the things with these clinics is that when people come in, as Ricky and Aiden both talked about, we have health coaching at the very end. So we do get them, it's almost like we set up different stations. So two of the places we use, we mentioned French Lick and Mitchell are the most, but French Lick, Indiana, we use the Melton Public Library. So it's a huge room. So when we show up, the students and all of us actually set up the tables and all the equipment before anybody arrives. So we're kind of like our own mobile unit. So even though we don't have a big vehicle or anything to do these in, we just haul everything in cars, get everything ready when we are there, and then pack it all back up and store it. So we utilize those spaces. In Mitchell, we utilize the Solution Center, which is also a big open room. So we just set up tables and really just have different stations set up. So once the participant gets all their vital signs, they get whatever results they're wanting, they go to the health coaching. So then we have that comprehensive information as Ricky had mentioned. So that way a registered nurse that has volunteered to be there that day goes over that information along with the students. So the students also learning how to go over some of those details. And if they do need follow-up care, we do what we can to get them set up, as some of the patient examples that were mentioned, especially the one that Aiden talked about with the participant that did have a high blood pressure, and really just had high blood pressure. There was no, they forgot to take their medicine or anything. We've had patients, I can think of particular ones that I've gotten set up with somebody that day. Like they even say stuff like, well, actually, I haven't seen my doctor in 6 months or something like that. And then we're seeing they've taken everything as prescribed, but they haven't really been following up, or maybe it's been a couple of years. If their provider isn't available for some reason, we do get in touch with somebody in that same healthcare group. So we've been able to do that for people, as well as a learning experience in rural areas with VA benefits. So we had a patient before come that does have VA benefits. However, there's not a VA in that area. So he wasn't getting proper care. And I think everything that we did that day, the results were high. And he was even having symptoms of like neuropathy and things. So we knew it was urgent to get him seen somewhere. It's not necessarily an emergency situation, but it was going to turn into that if he keeps going down the route he was going. So when I called local providers, one of the local providers that was actually just a few blocks up the road informed me that VA has to give benefits to people in their local area if they're out of a certain radius. So we were able to get him set up that day with that provider, and the office worked with him to get his VA benefits for that provider. So now he does have a primary provider in his own town so that he can have those illnesses managed, so that things didn't get worse for him. So we've had our own learning experiences to where we can then provide that for future patients as well.
Well, thank you for your information. If you want to share your contact information again, that way if they have any questions, they can reach out directly. I mean, they can always send us an email and we can forward it to you if nothing else. Well, I don't see any questions that have come through on my end. Oh, wait a minute. We have something. We do have one. It says, what are some of your biggest challenges?
I know Aiden elaborated on some of that. I'll let Aiden answer first, and then Ricky, and then myself.
So some challenges with the like screenings in general sometimes can be participation. We, as part of that clinical in our sophomore year, our community clinical down there in Paoli and French Lick, we would go out to patients' houses and speak with them about certain health problems. Let's say it was a diabetic and they needed help with what they were eating to get their blood sugar under control. And we would talk to these patients about how we had this free healthcare screening coming up and they could come and attend, get their A1C and all these other things. And sometimes it was difficult to actually get them to come out. Um, so it's important to be able to advertise the screening clinic well enough so there can be people that come out and actually get everything tested. Other challenges with them, and especially Dr. Arce's IRB, is sometimes just getting them to stick around long enough to fill out the survey afterward, like I was talking about earlier. Um, Sometimes people they could have had bad experiences with healthcare providers in the past, so they're coming to a clinic like this, which it is different. It's a lot different than an office visit. But they still don't want to be there as long as we would need them to be to fill out the survey. So they might just go through a couple of the stations and then kind of just want to leave after the fact. Or like Ricky was talking about, we've even had a couple participants who were brought in by, let's say it's an elderly woman, her daughter brings her in to get things checked on. And let's say the elderly woman wants to leave early. Sometimes it's hard to convince them to stay to fill out any surveys. Um, Besides that, I can't really think of any other super pressing challenges that I've experienced firsthand, but I'll let Ricky share any that he's had as well.
Yeah, so similar to what Aiden was saying with the barrier to access to the clinics and themselves, if they don't have access to good online materials, or if they just don't go anywhere to begin with for checkups, it would be kind of hard to see these flyers in generals for the screenings. So just like he said about the advertising, I think that's a big barrier for a lot of people. And then also when we get to the actual clinics themselves, I think health literacy might be another big thing. Uh, as nursing students, we learn a lot of medical jargon, we call it, but it's important that we know how to simplify the words. And it comes with experience for us to actually be able to explain things in a certain way that really make it easier for patients to understand what's actually going on with their body.
So one of the other things that has been a limitation more for me behind the scenes is funding. So getting the grant money, my goal is always to keep these free for the community. And the getting grant money, AHEC has been great the last couple of years. But sometimes getting that money in a timely manner before the semester starts can be a challenge. So far, everything's always worked out, so I'm grateful for that. But each one of the tests that we do, like for the hemoglobin A1C, for instance, depending on where we get it from, on average, it's about $15 per test. Sometimes we can get it for closer to 10. And then for the cholestech, those tests a lot of times are around $10 as well. So trying to keep these like actually free for the public has been a challenge. I'm trying to plug in my computer at the same time. Sorry, I have somebody helping me. So getting these to remain free has been a challenge at times. So far, it's worked out. And then I agree with the marketing of it. So not really having a marketing budget and using all the sources for the supplies. I think we would even have higher participation. Having those community relationships is crucial. So, like I said, we started the clinics a couple years before I even started collecting data to build a rapport. That was important to me, that I didn't want people to think, one, I was just coming and never coming back, or two, that I was just coming to collect information from them and that's all I wanted. So I wanted to build that rapport that we really are here because we care and we want to provide these screenings for you. It helps us to collect data so we can keep providing them for free, and that it's making sure that it's a need. With the advertising and everything, though, there's been some people that actually come and everybody's like grateful. Like people come and they're really thankful. There's a lot of people that verbalize that quite a bit, even with the students. And then they'll advertise as well. They'll be like, hey, here's my email. Let me know when you're coming again and I'll help spread the word. So they want people to come too because they know that it's a need and that people would appreciate it as well.
Okay, well, I don't see any other questions, so I just want to thank you guys for your presentations today. And again, remind everybody this will be on our YouTube page probably by Friday under our resource page on the IRHA website. And then I want to thank everybody else for joining us today. Everybody have a great day.
Thanks for having us.
Thank you.
Thank you.